Okay, looks like our numbers have stopped climbing. So, hello, everybody. Thank you for joining us today. My name is Sophie LaMarche. I'm a senior consultant with Bowling Business Strategies. And on behalf of BBS, Mercer, DMMA, and Doing Right by Birth, I would like to welcome you to the first webinar in our 5-part series called Birth Equity, Pregnancy, Parenting, and Drug Use. This series is led by Dr. Mishka Turplin and Dr. Kima Taylor, who will introduce themselves here shortly. And I also want to give a special thank you to Alethea, Brian, and Sherry of DMMA for getting us here today, because this would not be happening without them. So here we go. So like I said, this is the first webinar in a 5-part series that runs through November. You are all welcome to attend any or all webinars. Each one will be recorded and we will share the slides out after the session. Today's session is this one here in the red box. It is one of a 2-part session where Dr. Turplin and Dr. Taylor will talk about holistic prenatal care, with today's session focusing on screening, assessment, treatment, and beyond. The follow-up session will take place on September 11th at the same time, and that one will focus on barriers and facilitators to dyadic well-being. We will have one other webinar at the end of September, and then our final 2 sessions in October and November there. Please help us spread the word. The more the merrier. If you find today's session helpful and or are interested in our future topics, please feel free to join us and tell your network about it. Registration is now open for the second webinar. I'll flash this QR code up again at the end. And then, like I said, we'll share out the slides so you'll get the registration link if the QR code for whatever reason does not work for you. So, quick disclaimer, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of BBS, DMMA, or Mercer. And with that, I will turn it over to our panelists to introduce themselves and kick it off.
Thank you so much, Sophie. So, in theory, I can control this slide, and now it's not working. That's okay. Well, okay. Well, I did that. My name is Dr. Kima Taylor. I'm a pediatrician by training. Have also worked in public health for a long time, and really have worked actually quite often with Mishka on this intersection and how to really support dyadic well-being for pregnant and parenting people who use drugs. And I'm honored to be here today. I will pass it to Mishka.
Hi, everyone. I'm Mishka Turplin, OBGYN addiction medicine. Work primarily at Friends Research Institute in Baltimore. I'm delighted to be here, delighted to work on anything with Kima, and also really delighted to be working again with Rachel. Rachel, I'm going to pass it over to you.
Thank you. Hi, everybody. I'm Rachel. I am a person with lived experience. I am a recovering heroin addict. I'm 3 years clean, but my drug of choice was IV heroin. I used for about 8 years, and went through a pregnancy while using, and that somehow has led me here to this amazing experience to be a part of the journey to just helping in any way I can, and just glad to be here. Thank you, Mishka.
Awesome. Okay, and now we're going to try and do a poll. I told Sophie and Mishka we'd have to just do transparent facilitation because I cannot make the poll work. I thought it was down at the bottom before.
Yeah, I'll launch it. So we're launching the poll now. We would love to get to know you, if you don't mind filling that out and letting us know who's joining us today.
And this is, as Sophie said, for us to get a chance to know who's in the audience, but also for the audience to get a sense of, to know who's in the audience and who they should be, could be, possibly are working with in this space. So go ahead and fill it out. Like 30 more seconds. Awesome. Okay.
All right, I will end and share those results. So everybody should be able to see those.
Awesome.
Good mix.
Yeah. So this is who is in your group with you. And we'd love for you to share it around for the future ones, because we'd love for all of those boxes to have someone represent it, if not more than one person. So just for the introduction. Okay, Sophie, actually, can you just move the slides for me?
Yep.
We'll talk a little bit about why we're here, and that's really to talk about comprehensive treatment and medication, which are rare and unavailable for most pregnant people with substance use disorder. And so often we have these conversations about integrated care, and if you see the small portion of people who get integrated care compared to those who get evidence-informed care, that's part of what we want to talk about today, but really want to be able to talk more broadly than that, because it's not just like diabetes where, oh, some people aren't getting access to care. There's real stigma and discrimination and reasons why people aren't getting the care that they need and deserve for themselves and their dyad. And that's really what we want to unpack while we're also talking about how to provide this comprehensive care. So I'm going to stop talking for a brief period, and I would love to open the floor to Rachel to talk a little bit more about her journey, but really putting in the context of this is why we are here today. And this is what we're learning about today, and really putting in the context of nothing. We're not going to get to equitable outcomes, which we're going to talk about a little bit in the morning, unless you really involve the people who've been impacted, and particularly within the service areas and health concerns where there's much stigma and discrimination built in. So I'm going to turn it over to Rachel to get us started.
Thank you so much. So yeah, I guess just a little background. So I am from New Orleans. I did start my journey of using at 18, and it was just a snowball effect from there. And over those 8 years, I did experience a lot of discrimination, a lot of stigma, to the point where I just stopped going to the doctor. I stopped taking care of myself. It was just so embarrassing. Like, I was just so turned off by it. But just to be a little more specific, I'll tell you 2 stories, a good and a bad one. So there was a time where I did overdose and they brought me to the hospital, and I was in the room, and it was a very obviously dramatic experience. You know, my mom, my aunt, we were all in there crying, they're holding me. And the doctor walks in, and he just comes, he kicks his leg up on my bed, and he puts his arm, like he puts his head like in his hand, and he's just like, yeah, well, you know, you died, but at least this isn't a story where I have to tell your family that you're going to be brain dead for the rest of your life. And I'm like, yeah, thanks for that. My mom's sitting here crying her eyes out, and now she's just never going to sleep again the rest of her life. And honestly, all that made me do was want to go home and use more. And I know that's crazy, but that's just like my addict brain. Like, all that made me do was want to go home and do a big fat shot and be like, no, dude, screw you. Like, you're telling me I'm lucky? No, like, I'm fine with dying. I'm at the point where I'm kind of fine with it. Like, I accepted that I'm going to die a heroin addict. And if I do die from an overdose, well, that's just like my dream come true. Like, if I'm dying through an overdose. So that's what you're going to tell me? Never. No, I was so offended. My mom, my aunt, we were shocked that he said that. There was just no care, no consideration. And you could just tell that he's done it a million times. And I guess he was just over it. But going to a good story about it, though. So when I did discover that I was pregnant, I was actually homeless. I had no phone. I had no resources. My family had cut me off. I was sleeping in the local park. They kept their restrooms unlocked 24/7. So I would just sleep in there, or sleep in laundry mats because they're open 24/7. And I ended up getting arrested, and the jail actually brought me to the hospital that I ended up giving birth at. And so my first visit, you know, black and white jumpsuit, handcuffs, 2 deputy escorts, you know, the whole 9 yards. And I'm just preparing myself mentally for the judgment and discrimination that I'm about to receive when I walk into the room and meet this doctor for the first time. And he walked in the room with a big old smile on his face, and he like held his hand out and he was like, "Hi, Rachel, you know, my name's Dr. So-and-so. It's lovely to meet you." And he sat down and spoke to me like I was any other patient, like I was normal. And I was like, "Oh my God, he's so nice. Why is he being so nice to me?" And every time I went and visited him, he was like that. But if he had treated me any differently, I probably wouldn't have gone back. I probably would have never gone to the doctor. I probably would have, even though the jail was bringing me, but to say in other words, if I was out and I was going on my own, I would have never gone back. I wouldn't have gone to get checkups. I wouldn't have gone to anything. I probably would have just handled my pregnancy all on my own and given birth in a bathroom or something, just to avoid that stigma and discrimination, because it's just, that stuff is so heavy. I mean, I already am hard enough on myself about it. So to get it from a healthcare professional or anybody else, it's just, it puts me down a whole nother level. And I'm so grateful though that he treated me like that. And all the staff at the hospital, they treated me so well. They treated me with respect. And the biggest word I can say is normal. They treated me like normal. And that meant so much to me. Like, they didn't make me feel like I was a horrible person or like I am just the scum of the earth, like I was used to receiving. And that, to this day, like, thinking back on that, it makes me smile. All I can do is smile when I think of them. And I'm incredibly grateful for that experience. Because God, now me and my daughter, we are living a normal life. Like, I have a place now. I have a place and a car and a phone and a job. Like, everything is just so normal now. We're so happy, and I'm so grateful for them. I'm super grateful.
Thank you, Rachel. And she's a beauty.
Thank you.
So I want to, before turning it over to Mishka, I want to do some level setting just around definitions. And I want to first state that these are the definitions we're using. Other people may have other definitions, and I'm not saying those are right or wrong, but I think it's helpful for the conversation. When I use a word, you know what I mean when you're using it. And I actually think it's helpful for any conversation, but for this one, because otherwise we often throw these words around and wind up talking over each other because we don't mean the same thing when we say it. So starting with stigma, that stigma against people with substance use disorders is a set of negative attitudes and stereotypes that can create barriers to treatment and make these conditions worse. And this is there in full force. Often there's different stigmas depending on the substance, alcohol versus, say, heroin, but stigma exists. But I do want to state that this is different than discrimination, which is the unjust or prejudicial treatment of different categories of people, especially on the grounds of ethnicity, age, sex, or disability. Unfortunately, many pregnant and parenting people who use drugs face both stigma and discrimination. So stigma, negative attitudes and stereotypes. Discrimination, you're actually treated differently because of this. And then diversity is the practice or quality of including or involving people from a range of different social, ethnic backgrounds and of different gender, sexual orientations, and other intersectional identities. Next slide, Sophie. And so we often talk about, or I for sure, but we often talk about health equity. And the goal of this really is health equity, have equitable outcomes for all pregnant and parenting people who use drugs, and equitable outcomes for everyone. And I recognize that this is sitting in a larger context of maternal child health, poor outcomes. And so this equity that I'm looking for is truly across the spectrum. And equity is the absence of avoidable or remedial differences among groups of people. So you take away the fact that the doctor comes up and is like, you could have died. And everyone actually has to provide the quality of care that says, hi, my name's Dr. Taylor, and is kind and warm, comforting. And so it's the absence of avoidable or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Health inequities therefore involve more than inequality with respect to health determinants and access to resources needed to improve and maintain health or health outcomes. They entail a failure to avoid Health inequities entail a failure to avoid or overcome inequalities that infringe on fairness and human right norms. So what that means is people throw that health equity route around and kind of feel like they're done. No, this is an active thing we have to do to change systems and the way people are treated if we want to get to health equity. And that's different than health disparities. A lot of times people talk about health disparities, which are important. And it talks about health differences, closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who systematically have been excluded, systematically experience greater obstacles to health based on their race, ethnicity, religion, sexual, socioeconomic status, gender, age, mental health, cognitive, sexual orientation, and other other intersectional identities. But health disparities are different. We've spent so many years saying, you got all these health disparities and doing nothing about it. Health equity gets us to actually work to do something about it. Next slide. So it's important when I talk about a lot of these concepts, people often link diversity, equity, inclusion with equity and equitable outcomes, health equity. Diversity, equity, inclusion inside your institution, inside your work you're doing is incredibly important. And it includes all of the different intersectional identities. It includes making sure including diverse people with living expertise. All of that is wicked important for diversity, equity, inclusion, but it's not the same as equitable outcomes. Equity and access does not necessarily lead to equitable outcomes. We do so much work in the US saying, well, we gave you a card, or we thought you could go to the emergency room, but then the doc was a jerk. So, right, you go in, you have the access, but it's not going to lead to equitable well-being outcomes. So equity and access does not necessarily lead to equitable outcomes, and we really need to look at the outcomes piece. Equity and equity lens are necessary in all areas: policy areas, practice areas, program development, implementation, evaluation. That seems overwhelming. Start in one space and spread it. But it's needed in all those spaces because we've spent so much time historically taking out people who use substances. And so we need to re-envision a system where we really are going to achieve those equitable outcomes, regardless of race, ethnicity, etc. It requires changing the way we were taught and often changing the way we think. It's not a put on, people are like, just add health equity onto a slide or something. It's not an ad on our tag along. You don't do all the work and then be like, oh yeah, people use substances. Oh yeah, Black people. It's many different policies, practices, and programs already embedded in equity. So we have to do work to make sure they're equitable. So the key for me is equitable outcomes from all of our policies, programs, and practices. This requires getting and collecting data. There is one question that came up around LGBTQIA populations. We do a crappy job collecting that data. You're not going to get equitable outcomes if you don't even know where you stand, with caution that particularly in this space with substance use, data can be dangerous. So we have to make sure that we're collecting this demographic data and not using it to be harmful or to re-stereotype people or to take away from people because we have such a long history. The key really is equitable outcomes from this. And it's hard, but it's achievable. And part of what we want to do with this work and these slides and these conversations is to get all of us to think how we can play our part to get to those equitable outcomes, regardless of who you are. And as I said, this sits in a larger maternal child health fiasco where we have poor outcomes regardless of who you are, and then worse based on your race and ethnicity, and if you have some melanin. Equity really is for everyone. And making sure that we do that is kind of where I think for myself, a lot of the starting space is. So next slide. So that gets to what is the goal? Equitable access to and outcomes from culturally and linguistically effective. I use that language, culturally and linguistically effective. I speak Spanish. For much of my time seeing patients, I saw Spanish. But you can talk someone's language and not know their culture and really go to bad outcomes still, right? So it has to be effective. It's not my talking Spanish next to you. It's actually us engaging in a partnered relationships where we can have improved outcomes because we're working together and it's actually effective. And it's effective outcomes based on that partnered relationship and what the patient wants. Their goal is to have community-based, non-punitive, person-centered health and social services that seek to preserve and support families, support improved wellness for parent, infant, and diet. And you will note, I will not use the word culturally competent. I know a lot of people do. I've worked in a very diverse clinic. I will never be competent. I will be humble. I will learn to be quiet and listen, but really want to be that effective person as opposed to pretending I'm a superhero. Next slide. So just a little bit of level setting around Delaware, and I think it's important, substance use disorder among prenatal populations, to kind of get us to thinking, why do we need this? So Delaware is one of the highest rates of substance use disorder and opioid use disorder among pregnant and postpartum people in the US, and among the highest rates of infants with neonatal abstinence syndrome. It's ranked second in the nation for percentage of Medicaid beneficiaries treated for opioid use disorder, and 5.1% of those beneficiaries receive treatment, which is better than the national average. So I think that's something to be happy about, but we're still not there. 5% is not enough. And the other piece that come with this, right? We were talking about equitable outcomes. When you disaggregate the data and look at race, ethnicity, primary language, immigration status, then where do you stand and where are the pockets that you might have to do a little more work? So yay, movement. As I said, it's hard, so we got to keep moving. According to the Maternal and Child Death Review Commission, overdose is the leading cause of maternal death for the 4th consecutive year. And this breaks my heart, because when people were talking about overdose deaths earlier, we're like, hello, look at pregnant and parenting people, but no one really wanted to touch that topic area for multiple reasons I won't go off on. But no one really, and then now we're acting as if it's a surprise. So now at least there's some attention to overdose, but I would say that, as said in the slide, we really have to focus on substance use disorder, not just opioid use disorder, if we really want to affect these overdoses and get to the place where we have equitable, positive outcomes, where there's decreased overdoses for everyone. Next slide. And this slide is really, we're going to touch on this throughout the topic, but as you know, part of the reason people are loath to come in for prenatal care is that link to punitive child welfare. And this slide, though I won't read it to you, gets to that difference between stigma and racism. And you can have policies in place, but they often impact one group differently than another. So you need to have the data and you need to have the numbers. So Delaware does not have a large enough Black population that 48% of Black kids are in foster care and 45% entered foster care. Like, problem that is disproportionate. So that is why we need to collect data and really start thinking about what we're doing in this space and how we're going to get to those positive equitable outcomes. So now I am going to stop talking and turn it over to Shka or Dr. Turplin. Oh, right.
Thank you. Thank you, Kima. Thank you, Rachel. So for today, what we're going to talk through is a little bit about preconception, prenatal care, kind of lay the groundwork. This is one of two like webinars on prenatal care. We're going to talk about testing, screening, talk about treatment, talk about other health concerns, and then loop back around for a big picture that focuses on harm reduction and care coordination. So I want to just note, we're talking about pregnancy and parenting, but these take place in the context of life and in the specific context of a reproductive health life course. These are data or description from the Guttmacher, so it's the non-inclusive language. But thinking about the reproductive health life course, among people like who are capable of pregnancy, they might spend 5 years pregnant, postpartum, or trying to get pregnant, and 30 years trying to avoid pregnancy. So even though we're focusing on that pregnancy box for these talks, I want to make sure that we use these as a way to consider and recognize and embed it within the larger life course. So prenatal care, I'd urge us to think about what it should look like and to recognize that one size never fits all. And when we talk about it in general, and we will drill down more specifically, we're talking about linked care to the multiplicity of concerns that people have, and that this care is managed through the transition from pregnancy through birth to the postpartum period. As Kima detailed very well, we're talking about culturally and linguistically appropriate, effective care in all realms, and that it's not just about OUD. Although we begin with OUD oftentimes because it's easier to describe and it's more in the national spotlight. But we're talking about non-punitive community-based prevention, harm reduction, treatment, and recovery services that are evidence-informed, as well as physical, mental health, and social support services. So think what is available and changing to what should be available to improve health and social outcomes which benefit the individual, families, communities, and home visiting. It's a bit of a truism in obstetrics that the most important, prenatal visit is the preconception visit. This is the visit in which, we optimize chronic disease management in order to improve, birth outcomes. And CDC details a list of core requirements for, preconception care, which include knowledge of family history, being as strong as possible, as mentally healthy as possible, optimal weight management, avoiding toxic and other kinds of exposures, and minimizing the use of substances. And we know there's an association, we'll explore this more later, between sort of multimorbidity and birth outcomes. But prenatal care, because of the insurance structure in the United States, in which almost everyone who's pregnancy has access to health insurance, it's actually an opportunity to address the multiplicity of, conditions and the multimorbidity at times associated with substance use. And one of them that I want to highlight is syphilis. I think most of you are familiar with this, but we've seen increasing rates of syphilis over the past, decade in the United States, rates today higher than they were in the 1950s. And nothing has changed about the management of syphilis. The infection itself, we understand it as well as we understand any infectious disease. So this is not a knowledge gap. This is sort of like an implementation science access gap. And both rates of syphilis amongst pregnant people and congenital syphilis diagnosed amongst newborns has markedly increased. And CDC has noted a strong association between congenital syphilis and substance use, with illicit opioids having the strongest association, that people who use illicit opioids in pregnancy have 6 times the odds of having an infant with congenital syphilis compared to people who don't use illicit opioids. So let's begin through the agenda. Let's talk a little bit about how we assess people for substance use and use disorder in pregnancy. And I want to begin by defining terms. Screening is having a conversation with somebody or using a validated instrument. And testing is looking at a biological sample, a matrix such as urine, blood, sweat, saliva, hair, meconium, for the presence or absence of drug metabolites. And when we talk about drug tests, there are really 2 types. One is presumptive and the other is definitive. The presumptive test is identical in technology to the rapid COVID test. It uses an ELISA antibody, technology. It reports results within minutes, and the results are binary, positive or negative. Definitive tests are like the COVID PCR. They use a different technology of gas chromatography, mass spectrometry, tends to be a send-out test, takes days to a week to report results, but the results are specific and quantified. You get the exact compound and a quantity, usually measured in nanograms per deciliter. So one of the problems with presumptive tests is that they're sort of biased by substance. Things clear the body at different rates. So tests bias towards substances that stick around longer. And you can see this here. Alcohol clears within hours, amphetamine within days. Cannabis and cannabinoid metabolites can stick around for weeks or months in chronic users. So these test result biases towards compounds that clear more slowly. Presumptive tests, because they're binary, because they are based upon an immunoassay, are problematized because of false positives and false negatives. And this is a partial list of medications which cause false positives across a whole host of range of drug tests. And if we don't know this, we might misinterpret the presumptive positive as a true positive. But there's also a problem in the interpretation of true positives. These are 3 articles that look at fentanyl positive urine tests in newborns where the source of the fentanyl was the epidural that the pregnant person was administered during the birthing hospitalization. It's a true positive. It actually is fentanyl in the urine of the newborn, but the source of the fentanyl could be misattributed to illicit fentanyl rather than fentanyl that was given under legitimate medical contexts. And finally, health professionals, physicians, do not know how to interpret drug test results. There's a small literature on it, and it's all roughly the same. On the right-hand side here, these are 7-item survey that was given to general practitioners in Canada related to the interpretation of drug tests. No one scored 100%. The average score was about 50%. And in fact, people who said that they utilized drug testing in clinical practice scored 1 point lower than people who did not. So drug testing is not recommended by any professional medical society for the assessment of substance use or use disorder. The American Academy of Pediatrics is clear that a positive test indicates exposure, but it's not an indication of health or ill health, injury or harm, and is not mentioned in the discharge criteria. The American Society of Addiction Medicine says that if a presumptive test is going to change the clinical or non-clinical management of a patient, you need to have a better quality piece of information. You need a definitive test in that context. And finally, consent is required for drug testing across medical societies. In contrast, what is recommended is screening, ideally using a validated instrument. And further, participation in screening should reflect bioethical principles, including autonomy, which means that participation in screening should be voluntary. Because when we put this together, the two, I think, most important medical societies in this space, ASAM, American Society of Addiction Medicine, and ACOG, both have strong statements. ASAM says that equating a positive toxicology test with child abuse or neglect is scientifically inaccurate, inappropriate, and can lead to an unnecessary punitive approach which harms clinician-patient trust and persons' engagement in healthcare services. And the American College of Obstetricians and Gynecologists states that the laws, regulations, and policies that require healthcare practitioners and human service workers to respond to substance use and use disorder in a primarily punitive way require healthcare providers to function as agents of law enforcement. In other words, to some extent, the lane in which we work forces us or makes us feel like we're forced to act in ways that are against our own professional ethics. So to turn then, once you've identified somebody, let's talk generally about treatment. The gold standard for the treatment of SUD in pregnancy is comprehensive co-located service delivery. You take the universe of addiction treatment, which is medication when available, and behavioral health as well, and put it together in the same time and space as prenatal care. And when we talk about substance use services, we're really talking about the full range of person-centered, culturally and linguistically effective, non-punitive, evidence-informed SUD, not just OUD services, including cognitive behavioral therapy, motivational interviewing, contingency management, and making sure that the assessment for equitable access to and outcomes from these services remains standard and available. We have greater literature on opioid use disorder in pregnancy than we do other use disorders. So I'm going to focus on that more right now. In next sessions, we'll talk about other substances. But the literature on medications for opioid use disorder really emerges in the 1960s, and in the 1970s, there's a series of articles that look at the care of pregnant people with OUD. This is not the first article. This is from 1974, but it's one of my favorite articles, in part because Loretta Finnegan wrote it, but also because she highlighted a super important context. And you can see here, she's divided up the population based upon if they had OUD, not OUD, engaged in prenatal care, didn't engage in prenatal care. and looked at obstetric complications. And here I've also put low birth weight. And you can see the weight of the population health burden for low birth weight is actually amongst people with OUD who sought neither prenatal care nor addiction treatment. And when people sought one or the other, or even both, people had birth outcomes that were quite similar to the general population. 19.7% of people who received methadone and prenatal care had a low birth weight. That's closer to the 14% of people with untreated, with no addiction and sought prenatal care than it is to the proportion of people with untreated opioid use disorder who did not seek prenatal care. And so this reflects the principle, right? Healthy mother equals healthy baby. We optimize maternal health through the chronic disease management in pregnancy. And it's been shown again and again in the literature, including here from the state of Massachusetts. This is looking at this is not just OUD, this is SUD in general. And you can see again, the weight of the population health burden of preterm birth, low birth weight, fetal death, morbidity, and mortality, the neonatal period, really rests in the population of those with untreated disease. And when we treat addiction, birth outcomes look much more similar to a population without addiction, or at times even identical, than they do to people with untreated disease. So a lot of the literature really has, as I mentioned, has focused on medications. And this is sort of, the goal of medication for opioid use disorder. First is to stabilize the person, i.e., treat withdrawal. Then it's to kind of control cravings. And third is to achieve what we call an opioid blockade, which means if somebody takes an opioid while receiving medications for opioid use disorder, they don't feel an effect. But really, I think about, and all of that is true and important, we'll drill down a little bit, but I really think about medications as a platform for recovery, right? We know that people who receive medications are more likely to engage in other behavioral health services. There's a decrease in the acquisition and transmission of both HIV and Hep C. There's all sorts of domains of improvement beyond medical. And we know that people who receive medication are protected against overdose and dying of an overdose. And medications can be initiated at any point in time, during the birthing hospitalization, in the outpatient setting, postpartum. There is not a time where you don't start medications. And SAMHSA has summarized sort of the clinical guidance around medications with 3 high-level points. First is that medically supervised withdrawal is not recommended. Methadone and buprenorphine are the safest medications, and switching from one to the other is not recommended. So I want to drill down a little bit to medications for a moment and then introduce tweaks to probably what you learned about how to initiate medications that are important in the age of fentanyl. So we have 3 medications for the treatment of opioid use disorder. They differ in how they act on the mu-opioid receptor in the human body. Methadone is a full agonist, which means as you increase the dose, you increase the effect. Naltrexone is an antagonist. That means it turns off the opioid system and it stays off, no matter what the dose is. And buprenorphine is an interesting medication, and that's a partial agonist. It's sort of like a dimmer switch on a light, in a room. You can turn it on and you can rise it up, but it only goes so far. And that's the ceiling effect you see there. So at lower doses, more equals more, but there comes a point where the curve starts to flatten, and more does not categorically equal more. And this is one of the sort of benefits of buprenorphine. It makes it safer, but it also is the tricky thing in terms of initiating medication treatment. If somebody has 100%, binding of their mu-opioid receptor with any agonist, be it methadone, be it heroin, whatever, and we administer them buprenorphine, it's going to displace that from the receptor, and they're going to go into withdrawal. So how we want to start buprenorphine is we want them to have very little medication or very little heroin or whatever on their receptors. We want them to be uncomfortable, and then we give them medication that makes them feel better. This is a little bit backwards. This is purposely a slide from ASAM. Think about what addiction is. One of the salient symptoms of addiction is the inability to stop doing something you know is harming yourself and others. And we've set up medication to be like, we will give you medication, but in order to receive it, you must stop doing something for a while to be sick, and then we'll give you medication. So for 15 years, I think we've been a little bit backwards in how we've thought about medication initiation. And we've learned through what I'll show you with fentanyl that it does not have to exactly be this case. These pharmacological principles are the same, but how we administer medication does not have to follow be as sick as possible before we start medicine. So fentanyl is interesting. It has an active metabolite. That means that metabolite is bioactive, both of which are lipophilic and have slow elimination on the order of days. And so what people have been seeing is the older way of starting medication was precipitating withdrawal in some people. And to sort of illustrate this, this is kind of like the spectrum of buprenorphine dose down here on the bottom. And then this would be the risk for precipitated withdrawal. And there's actually kind of, it's a bell-shaped curve rather than, like an increasing line. So on very low doses, you actually don't precipitate withdrawal. And at very high doses, you don't precipitate withdrawal. And exactly where the top of this curve is a little bit unknown. And people smarter than me think it might actually be around 8 milligrams. So to kind of address both of those things, one, the age of fentanyl, and two, this backwards way we have of saying you got to be super, super sick before we give you medication. There have been methods to initiate people using, it's been called microdosing, it's been called low dose, and et cetera. And the first one that was described is here on the left is the Bernese method. And on the right-hand side, this is a link to all sorts of protocols around this. And I think they have one of the better current protocols looking at, what they call cross-tapering, as well as like low-dose initiation. And really the concept is that you start low. And you can use here some examples of using actually the patch, as well as using, sublingual formulations. But you kind of start at 2 milligrams, or I'm sorry, you start at 0.5 milligrams, and then you increase. You can increase slowly over the course of a week, or you can increase rapidly over the course of 24 hours. But the concept is that you're putting buprenorphine initially onto the receptor at a dose too low to precipitate withdrawal, and then you're increasing it from there, either slowly or rapidly. So this is one of the big changes in the last couple of years in buprenorphine in general, but also totally applies in the context of pregnancy. Now for methadone, we've had other, observations we've known for a long time that are entering more into practice today. So know that people differ in how rapidly they metabolize methadone. On a spectrum, some people are slow metabolizers, other people are rapid metabolizers. But in pregnancy, everybody becomes a rapid metabolizer. So that means that if you're taking a medication every single day and you become a rapid metabolizer, that you might become symptomatic by the end of the day or certainly by the next morning. And increasing the daily dose does not fix that rapid metabolism issue. So there's an emerging literature that is looking at the importance of split dosing, taking methadone twice a day, in particular in the context of pregnancy. And many people who are arguing that that actually should be the standard of care. That is the biologically, physiologically way to manage methadone in the context of pregnancy. So all of this is great that I've shared with you somewhere. Like I've told you, like we have an evidence base We know a lot about medication. We know about the effectiveness of medication. We know about the safety of medication. But taking a step back and looking at the population, most people with an SUD receive no treatment. Now, rates of treatment receipt are higher in pregnancy, but even then, and are highest for opioid use disorder, but even from these national data here, only a third of people with opioid use disorder in pregnancy reported receipt of any treatment. Now, if they received treatment, was it evidence-informed treatment? On the left-hand side, this is on the bottom. This is the population of people entering the, the official, like the specialty drug treatment system in the United States, who were pregnant and had an opioid use disorder. Rates of that increasing, in parallel with the opioid crisis. But the top line is the number of admissions that received medications for opioid use disorder, unchanged at 50%. And finally, there are marked racial inequities in medication receipt and dose of medication. On the left-hand side, these are data from the state of Massachusetts, looking among other things at the receipt of any treatment for OUD in pregnancy. And you can see here that Black non-Hispanic pregnant people had 0.4 times the odds of receiving any treatment compared to white non-Hispanic people. This probably reflects structural inequities. And on the right-hand side, this looks at the mean methadone dose at the time of delivery. And whereas white non-Hispanic people were receiving roughly 145 milligrams a day, Black non-Hispanic people were receiving less than 100 milligrams a day. And this likely reflects discrimination in healthcare by health professionals. So putting this all together, and you saw this slide earlier, you got the universe of pregnant people with opioid use disorder, of whom maybe a third, or SUD, of whom at most a third receive any treatment. Of those who receive treatment, only 50% receive medication, of whom only a smaller percent receive comprehensive co-located services, which we consider to be the standard of care and have been described as such in the literature for half a century. So to summarize, we need to think about how we change all of this in order to make MOUD accessible to all people with OUD. And MOUD should be embedded within a comprehensive treatment plan with wraparound service recovery supports that are culturally and linguistically effective. And we will talk about other substances in the next part. I'm turning this over back to you, Dr. Taylor. Thank you.
Thank you, Mishka. That was awesome. And actually, we are going to talk about whole person care in context, and particularly talk about harm reduction, which harm reduction is essentially secondary prevention, which we do for every other chronic disease, but is stigmatized and ignored for pregnant and parenting people, for all people who use drugs, but inclusive of pregnant and parenting people who use drugs. And I want to first open up and have Rachel talk a little bit about harm reduction, and then I'm going to come at the back end to close us up and get us ready for Q&A.
Yay, I love harm reduction. I love it so much. I mean, it tells me that like OUD is starting to be more recognized, I guess. Well, harm reduction can be used in any way, but like for me, I'll never forget, I ended up getting really close with like two ladies on the nursing staff at the hospital where I gave birth at, and they were just so supportive and so respectful and compassionate. And the day before I left, they were like, hey, look, like, we know you're gonna do great and everything, like we can see it, we see the like that love and that drive in you, but if you do happen to relapse or anything while your baby is home, just don't breastfeed, like avoid breastfeeding her. Try to find a babysitter if you ever need to go. It would be best to get someone to watch your baby, and don't use alone. Like, always have someone there. Always have someone there, and keep Narcan with you and with that other person at all times. Like those three things could have saved my life, could have reduced harm to Raiden. Had I did relapse and I continued to breastfeed, I would have been passing that on to her. Like those few things could have reduced so much harm. And I'm just a big supporter of harm reduction. I just think we need to normalize it and look at it like we do normal everyday regular things like driving. Like every day we drive. We know car accidents are one of the top reasons of deaths in America, but we still get in our car and we drive every day. We wear our seatbelts. We go the speed limit. We're supposed to slow down when the light turns yellow, not speed up. Those are examples of harm reduction, and it's normalized. We don't even think about it. We just do it. So same thing with substance use, don't use alone. Keep Narcan with you. Clean needles. Don't use after one another. And same thing with harm reduction with pregnancies. I'm just a huge supporter of this. I love this slide and I can't wait to hear you talk about it. Big supporter of harm reduction. I think it's so effective.
Awesome. And I want to actually also highlight the fact of the impact that providers can have when they're positive and helpful, right? Because I think a lot of times providers are like, oh, what does it matter what I say? And I think just being able to, as Rachel said, normalize being like, find a babysitter, right? We do that actually all the time, not even just with seatbelts, like for alcohol use disorder. We're like, okay, if you drink, pump your milk so you don't give them the breast milk from that. Get a babysitter, get an Uber, right? We do this all the time. We do it for diabetes. Okay, your sugar was high because you went to a party and had a huge slice of cake. Increase your insulin. So I mean, like, is something we do with everything, and it needs to be normalized in this space because it really is about the well-being of the parent, the infant, and the dyad. We have the tools, let's use them. But it's not just having the tools, it's what my mom always said, it's not what you say, it's how you say it. And I think Rachel is absolutely explaining how we say things as providers is incredibly important. Next slide. But I have to say for myself, for harm reduction, it is really holistic. Everything we do is harm reduction because everything we do is really about supporting that well-being. And as Mishka said, and as Rachel said, it's access to a full continuum of these services, a culturally linguistically effective substance use services, including that naloxone, including medications for opioid use disorder, full continuum of substance use services for every substance, not just opioids, right? Clean syringes as needed, wound care, pain management, and creating an environment. It's that access and outcomes, but it's creating an environment that people actually want to go to. That they feel welcome, that they feel supported, that they know that they can get the services they need without judgment, without hostility. And so they feel like they want to come back. It's access to culturally linguistically effective, non-punitive, community-based care coordination. And the other piece that's really important to me as a pediatrician that we don't talk about, it's also access to physical health services. A lot of times when people use substances, we'll like put them maybe 5% in the substance use treatment, and they'll have like a huge, massive wound, or their blood pressure will be out of whack. And the primary care docs or whatever aren't seeing them. No. Full access to physical health care services, mental health care services, including prenatal and partnered care. A lot of the things that we do, checking for gestational diabetes, checking for high blood pressure, if not taking care of, have worse effects than the substance use on the infant and the parent who we're doing this for. So really access to everything, and then assessment for equitable access to and outcomes from these services. We can't just do stuff. We have to see if it's actually effective. And then for myself, that includes, and I'm saying it again, really including people impacted. It's getting their input. It's going back to me like, did it work? We are human. We will make mistakes. The way you do more good is you go back, and when someone tells you you made a mistake, you regroup quickly. And you're like, how can we do it better? What was offensive? I'm really sorry. How can I do it differently next time? Really engaging in that partnered relationship. So next slide. And why? Because at the end of the day, our ultimate goal is equitable access to and outcomes from culturally and linguistically effective, community-based, non-punitive, person-centered health and social services that seek to preserve and support families, that support improved wellness for parent, infant, and dyad. And for some, that is defined as recovery. Next slide. And I say for some because some people don't use the terminology recovery, which is totally okay too. I was on a meeting once and I introduced myself as a Black woman and someone was like, no, you're African American. And I was like, well, I probably can describe myself. So allowing people the language they use for their improvement. One of the definitions is this definition of recovery that SAMHSA has put out. And this is, I have to say, a huge step. We have come far in the way that we define a lot of these terms. So this is recovery is a dynamic process of self-directed action. It is movement towards wellness rather than any single outcome state. Recovery is a process rather than an outcome. Abstinence, as one of many outcomes that may or may not fully occur across multiple domains of individual wellness, is thus a potential product of the process of recovery. And on the left side, they have the 10 guiding principles of recovery, which I think for many people, regardless of the language they use, these principles often hold. Next slide. So I think I'm turning this over to Sophie to briefly go through our next steps. Then we are going to open up for Q&A. And I just really, once again, want to thank Rachel and Mishka for this conversation and thank all of you for joining us.
Awesome. Thank you so much. Yeah, I'll keep this short. But like I said, our next webinar, which is part 2, a follow-up to today's session, is on September 11th at the same time, noon Eastern. You can use the QR code on the screen here to register for that, or I'll be sending out the slides afterwards. So you can wait and then be able to click that link. And then I think, anyway, here's some resources. Again, we'll send these slides, but just some websites and links that might be helpful to you all as a follow-up to this. And I think I'll stop sharing my screen now for the Q&A. And make sure that function's working.
Yeah, if people could put questions in it's the Q&A, it's at the bottom of the screen. Someone did ask if they'll get the recording, and Sophie said you will, but it's in the bottom of the screen. I think it would be next to the share for most of you. Don't be shy.
We also did, I know you answered some of the questions that we received via registration, but maybe as we wait for questions to come in, I don't know if you guys want to circle back to those.
Sure.
Yeah. Yeah, we received some of the questions by people who are registered. A couple of them relate to things that we will talk about later. And one question related to child welfare. We've touched on it a little bit, but it's really going to be in the session on birth. And we hope to have somebody who's a lawyer, who is an expert in CAPTA and in mandatory reporting come and talk during that session. There was I can't remember. I'm trying to pull them up and I don't, it's just some other ones too. And maybe while we're waiting for people, please ask questions.
Can I actually, Mishka, can I take one of the questions and ask Rachel?
Yes, please.
You talked to a little bit, but Rachel, you talked about this a little bit, but the question was, and I'm paraphrasing and I apologize because I don't have it right in front of me. That's because there's so much stigma and discomfort around pregnant parenting and substance use. What methods do you suggest for asking about substance use during pregnancy?
Okay, what do you mean? Like from a provider?
Yeah, like from a provider, how can you ask about that without turning someone off and making them not want to come in? I'm totally paraphrasing for the person, I apologize, but
No, you're fine. So definitely your approach is a huge factor. Like you have to come in, welcoming and open and understanding, and that will make me want to open up to you. Just build that trust, because then like if you put off any type of judgment, I'm not going to open up to you because I feel like I can't. And then a big thing, I don't want to speak for all users, but for me personally, is to not don't make me feel forced. Don't sit there and be like, you have to do this, you have to do that. This is what's best for the baby. You can say things that are best for the baby, but if I feel like you're forcing it on me, I'm gonna take a step back. But if you just kindly put it out there and say, look, if you're interested, if you'd like, we could take some of these steps, or we could do this, and that. And you make me feel like it's my choice. Like I'm going to do it. But if you make me feel forced in any way, I'm probably not going to do it. And I don't know why I am like that, but that's just how I am. And that's exactly how it went. He just made suggestions on what would be best. And I said, I was comfortable enough to be like, you know what? I trust you. I trust your judgment. And I agree. Let's do it. I want to do everything. I want to do everything I possibly can. But if you make me feel forced or make me feel like I'm stupid, I'm not gonna do it. Not gonna do it, because I'm just embarrassed at that point. So that's just a nice approach.
Can I say something that Rachel, because you're like, it's just me. Most people actually, when they're forced to do something or made to feel stupid, they don't want to do it. And so again, it's like normal human behavior that providers seem to go in this weird mode about. But I'm really glad that you brought that up, because that is that idea of partnered care, right? Working together.
Yeah.
So I hate to put you on the spot, but there's another one. Awesome. Okay. I'm a community health educator for Nemours. Should probably mispronounce, because I'm not a provider. How can I best support pregnant and parenting people who use substances that I may come in contact with in the community? So they're not a provider, they're a community health educator, but they want to be able to support pregnant and parenting people who use substances.
I guess I would just say, just to try to be as like, I want to say open. Just let them feel that you are very open-minded and willing to try to understand as best as you possibly can. Because obviously, like, if you haven't been there, you can't fully understand what it's like. But if I can see that you are really trying to connect and form like a genuine connection and bond with me, and you're trying to understand my addiction, that I appreciate that so much, because that means a lot. Most people are like, oh, no, you're an addict. I don't understand that. How can you choose drugs over your child, or this, and that? And it's like, well, you don't understand. So you can't speak on it. You can't have an opinion because you just don't get it. I am one. I don't get it. Like, I don't even know why I do that. I just did it, and I am. And it's horrible, but that's just the way it is. So and then just building that relationship, like those nurses did with me. We built such a relationship. I still talk to them to this day. I love them so much. But if they didn't make me feel comfortable when they told me about like harm reduction, I probably would have took it a different way. But because I was so comfortable and I saw that they respected me, I took it, and I considered it as soon as I left the hospital, everything they said. So I guess just try to be as compassionate and willing to understand and relate as much as possible. I feel like that would just help a lot. It would help me, and I would see it. But I did want to touch on something from the last question. Definitely don't make like threats, like that one doctor, like, you could have died, you could have been brain dead. It's like, I already know that. I already know those things, and I don't care. So making threats isn't going to help. If anything, that just makes it worse. I just wanted to say that. I wanted to put that out there.
Thank you. I think I cut Mishka off before, so if you want it.
No. Thank you, Rachel. And like what you're saying too makes me. Sometimes I use this turn of phrase, and I don't, and you said it so nicely in your the first or second time you spoke today, but that one thing I've observed working with people with use disorder, people who use drugs, is that they're highly intelligent around social dynamics and highly attuned to stigma and to discrimination, because that's like an important part of the landscape that you navigate. And also the way you said it a little differently though than I'm about to is that you can beat yourself up much more than any provider ever could. We can make you feel bad. We can make you feel small, but you can make yourself feel even smaller. And so if my goal is to hurt somebody, I actually can't hurt you more than you can hurt yourself. So I'm going to fail at that goal. So there's a way of like flipping, like even if that's my motivation, which it's not, it will be unsuccessful. And really kind of what I heard from you was like, you kept saying like, treated me like a normal person, and that sort of, and that was about how you create like a welcoming environment. And it's something we can do as individuals, but also it's about the system too. And that individual physician you describe actually overcame, I think, a whole lot of unwelcomingness as you went from, the transport, through, the clinic, in jail clothes and, shackled. And so that attests to like, yes, we need a massive welcoming environment, but our own actions of human dignity and treating people with dignity and respect and treating people like how we, would expect to be treated and et cetera, like goes a huge way in sort of undoing, not, or at least like it elevates that encounter more than, the structural, environment in that moment. And really the other thing you said had to do with trust and mistrust, and that you entered into that moment expecting mistrust, expecting or mistrustful, legitimately mistrustful because of the accumulation of your prior experiences, which justified mistrust. And really like the power of being able to undo that by, asking questions, by treating people like people, and by all of that. So, so thank you for sharing that. And that was what I was going to say the same thing all over again.
There's another question that I'm going to start with Mishka, then I'm going to add for the baby part. But if we screen a mom who's positive, what should be the next steps to appropriately get her the support she needs while also ensuring infant safety? As a family practice provider, is it appropriate to provide treatment, or do we need to refer out for treatment? I would like to provide the treatment, especially in light of the low MOUD rates for pregnant and postpartum moms.
Yeah, I'll just briefly, I mean, I think use disorder is one of the most common conditions that any provider is going to encounter. And I think, as an obstetrician gynecologist, I have a comfort with some degree of other disease management. And everyone has, I can start people on antihypertensive medications. I can add a second one. At some point in time, I'm like, oh, wait, like I'm no longer like the expert for this. Let me get someone else's help. Same with, a lot of, common psychiatric conditions. I can either initiate or maintain medications, but there's a point at which I recognize, that my expertise, I'm at the end of my sort of expertise. And so everyone's on a different place and we're all trying to expand it all the time. So I definitely think conceptually, yes. In fact, outpatient treatment that is centered in a family medicine practice is perhaps the best place to get addiction medicine services for pregnant people, and in particular, I think you'll talk about this, chemo, like postpartum when you've got also bringing your kid in. There's some barriers to doing that and whatever, but there are lots of resources. We'll share them with you in terms of like getting trained and initiating medication, and more importantly, who to call if you have a question. I work on something called the UCSF Substance Use Warm Line. It's a free service for all providers across the United States. You can call and get connected to somebody who can answer questions around medications for opioid use disorder or other kinds of things. And so having, so it's not just getting the initial training, it's what are the resources for sort of maintenance and support of skills. And then finally, just, yeah, knowing who, like knowing who else to refer people to when you know, you're no longer, you know, as comfortable.
Yeah, and I just want to add to that. I'm a pediatrician, but I love family practitioners. And I love because they can take care of the whole family and really see things in context. And as a result, often have really much more family preservation focused brochures and information and way they do business. And with that in mind, just looking at that while also ensuring infant safety, again, it's not that different, right? If someone comes in and they have high blood pressure, you absolutely get them in treatment as soon as possible, because caring for the parent is caring for the infant. And that's what you want to make sure that you're able to do. Making sure, we were talking about plan of safe care the other day, and I was like, that's what we pediatricians and you family practitioners do all the time. You're like, cover the plugs up so your kid doesn't stick a fork in them, right? Make sure that when someone's crawling, you baby proof the room. And so it's the same thing, ensuring that safety. And I think family practitioners are a unique position because you've had that relationship, and you can build with the kind of the input that Rachel's providing, that trust, if done appropriately, in a way that really can ensure the well-being of the parent and the infant. And I would say the most important thing, and this is as like for any parent, I would say, mom, creating an environment where they can ask questions. So if the parent is afraid of something, even if it's something like, I don't think this breastfeeding is going well, making sure they can say, I don't think this breastfeeding is going well. Not that here's the pregnant person who used drugs who's now coming in asking about right. Just get the lactation consultant and have them work with it, like creating an environment where people can ask questions. But with that, it's also, and this is something I think that's happening in a lot of places around the country, you really do need to see and assess what's out there. Because there are a lot of treatment and other providers that are out there that don't provide culturally and linguistically effective, much less evidence informed, much less warm and inviting care. And you don't want to ruin your relationship by sending someone to the wrong provider. So part of it is also getting a lay of the land. And sometimes that can be done in partnership with others. But I think a lot of often when I would see patients, I'd be like, Mom, like, where do you go for X? Where do you feel is comfortable? So actually talking to the people who are getting the care is like the best network adequacy thing you can do. As Mishka says, when you refer that to someone else, they'll be like, well, me and all my friends go to X place. And you can say, and then you tell the next patient, like, this is what I've heard. They speak Spanish. They recognize that, you don't have Medicaid because of Clinton's 5-year bar and blah, blah, blah. And they get, right? So just also trying to get a lay of the land. But I do, as Mishka said, I think it'd be awesome if you initiate a treatment and it's possible. Sorry, I cannot see well, so that's why when you see me like zooming in, I'm looking at the screen. I think this one is worth saying. I don't have a question, but I wanted to thank Rachel for being so brave in her recovery. My daughter and I lost her father in 2021 to fentanyl poisoning. I now work with pregnant women who are overcoming substance use, and it's very rewarding for them and their families. So we thank you to Rachel.
Thank you so much. I'm so sorry to hear that.
Yeah, I'm sorry to hear, and I'm impressed that you're working with others.
Mhm.
Other questions? Oh, how can we best train students, medical students and residents? I'm also going to add to this, nursing students, PA students, medical assistant students. So how can we best train students on social work students on talking about substance use with patients? Mishka, do you want to start?
I mean, I guess I'll just reflect that, and I'm sure I know it's the same way when you were in medical school, Kima. Like, we got no training. There was one brown bag lunch at noon where a person who ran the Haight-Ashbury Free Clinic came and gave a talk, and that was it. And it was you could just go and listen to this person for an hour, and that was the entirety of addiction education in my medical training in the 90s. And things have radically changed. Not changed enough, but there has been a much greater attention to to the topical area. I guess I would also say that to a large extent, the younger people, the students, and the residents, the people like the younger people are not all, but know how to talk about this actually better than their their bosses do. But what we need to do is things like this. I think, having access to educational sessions and including, people like Rachel with living experience, like in the trainings, and also to just center it on basic professional ethics as well. Nothing that we're talking about is in conflict. It's actually, it resonates with classic bioethical principles of, like do no harm, treat people like people are autonomous. Participation in healthcare, is voluntary, knowing that people who are engaged in their care have better outcomes, involving, the support people that people identify is improves outcomes. All of that is non-specific to addiction. So there's a way to do it that is specific about addiction, and there's a way to do it that is, more broader and actually about, equity and health and societal betterment.
I think I want to answer in two ways. One, I completely agree with everything Mishka said. But one, I really do want to stress it's not just medical students. So we did some work around buprenorphine, expanding access to buprenorphine, and often the nurses stopped it from happening. And then if you saw in Rachel's story, was the nurses were incredibly supportive. So we need to all train all students, social workers, everyone. The second thing I'll say is I agree with Mishka, we were not taught in med school, but way back when I went to med school, we did have these things called OSCEs. Don't ask me what that stands for. But what you had to do is at the end of medicine, you had to go through these rotations and have a sample patient. And the patient would come in and you didn't know what they were, what it was going to be, but you had to be able to, by the end, they had to come out and say that they understood what was going on with them. They felt that they wanted to work with you in partnered care and that they had a clear understanding of next steps. And so those sort of things, like it wasn't based on how you thought it went, like the patient got to rate you. These patients were paid because this is not completely benign, right? But I think that's something that maybe can happen with substance use, right? Asking people with living expertise, pay them to come in and talk with med students, because whenever a lot of times you do the trainings, even around equity, and you're like, well, I'm not going to do that ever again. And the next time you're scared and see a patient, it all falls apart. If you actually are prompted and the person's like, don't say that, say that, like in real time, often that helps. And I will say those OSCEs, we did them for many other chronic disease. This, when I was going to med school, was early on in HIV. And there weren't cures for HIV. Well, there's not a cure now, but there weren't even the remedies we had now. So it was really around that. And it makes you humbler because you realize all the ways you make a mistake. And it makes you realize you don't want to hurt someone. So you listen better to how to do it better. So there are some concrete ways you can do it. Rachel, do you want to add anything?
I guess if there was like one thing I could say to anybody and everybody involved, just know that no matter how big or small of a role you have in this person's life, recovery, pregnancy, anything, you are a factor in how that experience is remembered. Like when I think back to my hospital stay and my birthing experience, I get happy and I smile. Some people I know, when they think back on their experience, they cry and they have this, one of the most beautiful experiences of their life, giving birth to their child, was ruined by stigma and discrimination. A memory that should be full of joy and happiness is replaced with just trauma. And so I guess I just want to say, even if you're not a provider or anything, you're just a person involved with somebody's recovery, just know that you are a factor in how it's remembered. And word of mouth, like when I was bad off, we say the word on the street, like that stuff's real, and that gets around. Like I put out a lot of good about where I gave birth, and that travels. So that's also a factor. You don't want a bad word of mouth. You want people to hear good things and let them know, okay, that is a safe place for me. I can go there. You know, because I didn't have that. I didn't have the knowledge. I didn't have any of that. Had I known that there was a safe place I could have gone to get Suboxone early on in my pregnancy and not face repercussions, not face disrespect or stigmatism or anything, my pregnancy would be a completely different story. It would be a completely different story. So I just want to say that that's a huge thing.
Thank you. And what you were saying made me think about when so I ran a clinic for a while, and I used to have, it's sort of related to medical students periodically, and even residents rotate like with me. And one thing I would do anyway is, especially for new patients, ask them like, why, kind of, how did you come to be here today? And oftentimes there would be a story of somebody treating them with respect. The last time I went to the ED, somebody, like I was treated a little bit differently, and they gave me the phone number to this clinic, and I would reflect on how like that person in the emergency room does not know the outcome of that event, right?
Yeah.
They did something human and decent, and they will never know what happened from that. And almost every person I saw in clinic had a story like that. It was never fed back. You couldn't feed it back necessarily. So it reflects, more of a principle of like living in the universe. You put, like you said, you put good things out and you trust, one, it's the ethical thing to do. And two, it actually, it's going to have effects that you won't see. But that does not mean that they don't happen.
Yeah. Okay, I think this is the last we have time for Rachel. You're busy. What was or is the hardest thing you found yourself having to overcome during this journey?
Like recovery journey or just in general?
This says journey. Answer it the way you feel best.
The hardest thing to overcome? God, definitely all the internal damage I did to myself throughout that whole process. So I guess once I did get sober, and then I started to feel everything again, everything just kind of came crashing down and hit me like a brick. So I guess working on myself once I got clean and facing everything that I had done during my addiction. But as far as like pregnancy wise, the hardest thing for me, which I am grateful for at the same time, was watching my newborn baby go through withdrawal. That to this day is probably the hardest thing I've ever witnessed in my life. Just watching her detox and go through withdrawals was hard. I mean, I cried for hours and hours just watching her, but I never ever want to forget that, because that is one of the things that will make me never go back. Like if I ever even have the slightest thought of using again, I picture that. I picture my daughter. And I just remember her going through that, and then I just immediately forget about it. I'm like, absolutely not. Like watching her go through that is a huge factor in what keeps me sober today. So I want to remember that pain. I want to remember that. I need to remember that for my recovery. And here I am over 3 years, and things are going really, really well. That was the hardest thing.
Yeah, and thank you for being so honest and being willing to share. And I do think it goes back to kind of what both you and Mishka are saying. No one's harder on you than you yourself will be. As a pediatrician, I always tell people, hug yourself and forgive yourself, because parenting is hard.
Yeah.
And I think that gets to something else that Rachel and Mishka alluded to. And I know this sounds sappy, but it really is about love, right? If you look at particularly a period of pregnant and parenting people who use drugs, oftentimes that is the time when people really want to and are willing to connect. If there's opportunities that are available that aren't hostile and mean and supportive, often even if someone does relapse, like we have to have those support systems around them because it is about love. If you watch the way that Rachel was talking about her daughter and engaging with her daughter, as she said, it's just like everyone else. And how do we provide the support so people can live together and love one another? And Rachel can share her awesomeness with her daughter and vice versa, and they can grow together. And that's why we like to do these conversations. We are going to talk about prenatal care and postnatal care and eat, sleep, console and all of that in some of the future ones. But even with that withdrawal, the sequelae are the after effects, they don't last. So it's like, how do we then provide that developmental support? Because it's all about love. And that's what makes and I know this sounds happy, but that's what makes our country go around. That's what makes us be able to have those ability to talk to others with kindness and wellness and support. So I'm going to, once more, we have 3 minutes. Thank everyone for being here. See if Rachel and Mishka want to have a sign off and then pass it to Sophie.
No, just thank you, everyone. Thank you, Rachel, in particular. It's always, I mean, I'm so appreciative of the times that we've been able to share these sorts of like events and there are all these comments in the Q&A, and I'm sure people have things that they didn't write in there, but the impact of your existence is immense.
Oh, thank y'all so much. I appreciate it. Yes, I enjoy working with you as well. I love the way you put things and you word them and you make them so understandable, especially for me not being like a medical professional. I'm like, yes. The whole time you or both of y'all were presenting, I'm just nodding my head to everything you're saying. I thought my head was gonna like come off. I'm just like, yes, this is great. This is good. This is such good information. But I'm just super grateful to be here. Any way I can help, I will always try and help. So thank you for having me.
Awesome. And thank you to Mishka and Kiva for an engaging session today. I just put in the chat the link to register for our next session, which is on September 11th at noon Eastern. So feel free to sign up there if you're interested and available to join us then. But with that, I think we can conclude. So thank you again for joining.
Thank you all so
all.
much.
Thanks,
Everybody. All right.
Thank you.